Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Aimee.
She's known as the Egg Whisperer.
Fertility expert Dr. Aimee today.
And you have yet another success story
just launched by an East Bay fertility doctor.
Hi everyone, thank you for joining me on tonight's Egg Whisperer show. I'm super excited about tonight's topic because I can tell you one of the most common questions I get from patients is, Dr. Aimee, how soon will I be able to be pregnant? And I totally get it. When you've waited for over a year, let's say, and you finally make the decision to come see me and you're ready to do treatment, certainly you want to know how soon you can reach your goals. Whether it's 1 year, 3 years, 6 years, I've definitely seen it all. And I totally understand and appreciate how everyone just wants to be able to get to their final destination as soon as possible. But when it comes to pregnancy, I know that there are no guarantees. The reality is that it can be hard for a lot of people, and no matter what happens, it's always going to be okay. But I want to share with you my strategy, and you've heard me talking about this on the show. I've talked about the Egg Whisperer diet, which stands for diagnosis, IVF, endometrial testing and transfer. I've talked to you about building your fertility team, which is finding a therapist, someone to talk to you and help you with exercise and eating, acupuncture, mindfulness, and meditation. So even if you don't have a mind-body center around you, you can certainly create one for yourself. So I want to go through all the things that I talk to my patients about in my office so that no matter where you are in the world right now, you can hopefully learn from me and do the same things near you. So let's talk about the Tushy method. So I came up with the Tushy method almost a year ago in May of 2018. That's when I launched it. I launched it because I got so tired of people telling me, Dr. Aimee, I've done 6 cycles of Clomid and I still don't know my diagnosis. So with these 5 simple tests, it doesn't matter who you are, where you are, what doctor you're seeing, you can do these tests on your own. So the T stands for getting your tubes checked, the U, your uterus, S, the sperm, H for hormones, Y for your genetic profile. But how does that actually, look on a calendar? So that's what I'm going to show you right now. So if you're in studio right now and you were outside in the parking lot, what you would see is that you would actually see that my car has a big banner or a bumper sticker on it that says, when your period starts, call me. And literally that's what I tell my patients because I never want a patient to feel lost, confused. What do I do next? It's simple. If your period has started, I clearly am not done with my work. So please call me and let me know because I always know the plan because I listen to my patients' stories. I formulate a plan with them and then we decide and agree as to what makes sense for us to do next. So let's go through all the steps of the Tushy method and how you can get it done in one cycle, okay? So number 1, period starts, obviously, that's really funny. Obviously, call me, and what will happen is we'll put in an order for your hysterosalpingogram, and every imaging center is different. So some imaging centers like to do the hysterosalpingogram, which is the tube test, the T for Tushy. They like to do that around cycle day 6 or 8, or before day 10, some are before day 12. Some require you to call when you're still on your period. So if you've stopped your flow and called them, let's say cycle day 5 and you're ready to schedule, well, it might be too late and that can be disappointing. So make sure you know what the rules and parameters are for the imaging center that you're going to be using. And I highly recommend when your period starts to call your provider, or at least have the order in place ahead of time so that this HSG test can get scheduled. So if you're seeing me as a new patient and you haven't had your Tushy checked, at the new patient visit, we'll always do an ultrasound to look at your uterus. If not, if let's say a patient wants their Tushy checked and they haven't seen me as a new patient, oftentimes I will do these elements ahead of time, meaning I'll check all the elements of the Tushy, but I'll wait for the ultrasound until I see them in person. However, there may be a situation where I'll want to do an ultrasound and I can do that between cycle day 1 through 4 so that I can also accomplish checking everything else. And everything else on day 3 would be the hormones, FSH estradiol and AMH tell us a little bit more about egg quality. A preconception panel makes sure, for example, you don't have a thyroid disorder, low vitamin D, and abnormal prolactin, and that you're still immune to measles, mumps, and rubella. And of course, the Y, which is your genetic profile. So when I look at a patient's genetics, I'm looking at a number of things. I'm looking at their reproductive genetic profile, looking at variants related to, for example, miscarriages, blood circulation issues, immune response issues, and early menopause. I also look at a carrier screen to see if they are compatible with the sperm source. So we look at genes, for example, like cystic fibrosis, Tay-Sachs, spinal muscular atrophy, and Fragile X. I also look at cancer genes, other health-related genes related to, for example, heart conditions. And I also look at genes related to something called pharmacokinetics. Pharmacogenomics is another term that we use. So these are variants that tell us how a patient will metabolize fertility drugs. These are all very important things, and I'm always looking for tests that I think will inform my patient's decision-making, so that whatever treatment they choose, they're going into it with their eyes wide open, and they understand that what the expectations are before treatment. That's my goal. So if you walk in and you expect something to happen the first time and you have a high expectation for the number of embryos you're going to get, and you don't get that number, well, certainly it can feel like you've lost something. So I always teach patients about the fact that sometimes you have to grow a certain number of eggs to get the number of embryos that you're meant to get. And when you get embryos, it's always a gain. Even if you start with a higher number of eggs, the number of embryos that you might get could be lower than the eggs that you retrieve, but that's just because you're a human being. So the other thing that we also order, if it hasn't been done before, we like to repeat it, is the semen analysis. So taking a look at sperm health is really important, and we like to do that before ovulation because that will also give you an opportunity to also try naturally if you choose or want to. I can get all these results back within about 2 weeks. And once I get the results back, I set up phone consults, I review the results with my patient, and we talk about what are we going to do for treatment. And if there are any additional tests that we should be doing. For example, should we be doing a saline infusion sonogram to look more closely at the uterine cavity? Should we be doing a DNA fragmentation test to look more closely at the sperm? You've heard me say things like, you can't judge a book by a cover, and the same thing goes with sperm. Should we be, for example, taking extra egg quality supplements and sperm health supplements before we move forward with treatment? And should we be preparing for IVF treatment and using certain drugs, for example, like HGH ahead of time? So these are the things that I like to talk to my patients about. And by getting your Tushy checked and really looking very closely at everything and asking yourself, what does this mean? What does this tell my doctor about me? And should I be repeating certain things or doing other tests given this information? Those are the things that I'm always thinking about, and you should as well. So what I want to do is lay things out on a calendar. The title of tonight's show is How to Get Pregnant in 3 Months or Less. Again, there are no guarantees when it comes to human biology. However, if you use the strategy that I'm trying to teach you tonight, I think that your chance of success could potentially be higher rather than just transferring and hoping that something's going to work. My approach might be a little bit different. I don't take embryos for granted, and certainly I understand that even with this approach, sometimes things don't work. But what I find is that if you go through the steps that I'm going to describe to you tonight, your pregnancy rate with a high quality genetically normal embryo, your live birth rate actually, will be over 70%. And I certainly want all my patients to get pregnant as soon as possible, but sometimes we have to let go of those timelines, and I'll tell you why as we get through this calendar. So let's just say a patient's period started today. So today is Wednesday, March 6th. What I'll do is I'll have her come in today or tomorrow for what I call a baseline ultrasound. The calendar that I'm showing you right now is something that I would have made in advance. So for example, if I talked to someone in February and we checked her Tushy in February, what we would do is then make up a mock type calendar so she can see what her life would look like for the next 3 months. And this is what I would do for you. And certainly you don't have to do everything on this calendar, and I'll tell you why. So at the baseline appointment, we're going to review a number of things: the protocol, the side effects, what to expect, and your IVF must-haves. I'm going to talk to you about when you should stop having sex and when you should stop exercising. All my recommendations are individualized for patients. So I have some patients where I really want them to exercise as much as possible up until a certain day. I have other patients who I want to stop exercising as soon as their cycle starts for a number of reasons. But for the most part, I don't tell patients to abstain from intercourse. From start to finish, and I call this calendar step 1. From start to finish, it's 5 visits. The baseline, 3 monitoring visits, and then the egg retrieval. So at the baseline, like I said, it's a 1-hour visit. I'll then check your hormone levels and make sure there isn't a cyst. So if your FSH and estradiol look good, we're ready for takeoff. If there's a cyst, then we say we're just going to wait a month. So cysts are normal. They're just part of, having ovaries. We make a cyst every time we ovulate, and some of the time that cyst just hangs around and just needs another month to go away. And there are some patients for sure who use IVF readiness pills. So I call birth control pills that because some people use them to just get their body ready for IVF. And obviously, it kind of sounds weird to put a patient who's trying to get pregnant on birth control pills. So I use that terminology so people understand that you can use them for IVF and still try and get pregnant. We're certainly not trying to control birth. We're trying to improve your chances, and taking the pills can sometimes help in very specific situations. So the first visit, like I said, is about an hour, but those 3 following monitoring visits are about 15 minutes each. So you'll come into the office, I'll do an ultrasound, I'll look at the follicles, I'll tell you how many are growing. I'll also give you a better idea as far as when the egg retrieval is scheduled. We don't schedule the egg retrieval in advance. Your ovaries are going to tell us exactly when the egg retrieval should happen. The egg retrieval day is also the day for sperm collection. So I'm not laughing, I'm just laughing because every time I put my hand in, it seems like it's disappearing, and I think that looks kind of funny. So the egg retrieval day is a day where you're asleep. You're taking a nap via IV sedation. So what will happen is you'll check in 45 minutes before the egg retrieval. You'll meet the nurse. The nurses are wonderful at the IVF lab that I work with, at all of them. She'll get you all dressed in a beautiful white cap and a blue gown that's hooked up to a bear hugger. So that means you can insert this really cool tube and it makes you super warm, and these really fancy purple socks. And then I show up 45 minutes later and I will have my clothes on and you won't. And it should always stay that way. So we'll walk into the operating room together, and then you'll go to sleep. And when asleep, I'll place an ultrasound inside the vagina and I'll retrieve the eggs. We do that with a long needle that goes through the vaginal wall. It's really small. It's about 17 gauge. It's a 17 gauge needle. And then we gently aspirate the fluid that's inside each follicle, and that fluid will go into a little tube. The tube will get handed to the embryologist, and then she or he will then identify the eggs and let us know how many eggs we have by the time you wake up. And then your partner will be in the semen collection room at the same time. So we want your partner to have a really good breakfast and be really well rested so that he or she can support you for the rest of the day that day. Once you get home, you'll be wanting to take a nap, take it easy, but 95% of my patients are able to go back to work the next day. 5% just need a little bit of a break. So after the egg retrieval, we learn a lot. We learn about how many mature eggs we had. We learn about the fertilization rate. And then sometimes we do a procedure called ICSI. And I also offer my patients something called PICSI. So that's where you can plate a sperm on a dish, and that dish has a certain substance on it that attracts morphologically normal sperm cells that tend to be more genetically normal as well. So that's like putting the sperm through a filter before you also pick the best looking sperm from under the microscope. Over the next 5 and 6 days, we watch these embryos grow, and I give my patients reports. And I'm always telling them, this is what we have, this is how I feel about what we have, and this is when we will be expecting the next report. And what I always remind my patients is that it's not over until it's over. For example, sometimes I have a case where I get 5 eggs and we get 1 embryo, and we can feel super disappointed about that 1 embryo. And that 1 embryo is the one that turns into a healthy pregnancy down the road. So I always celebrate anytime I have an embryo, but certainly I keep things very realistic and always transparent with my patients. So 5 days after the egg retrieval, we do something called biopsy and freeze. And that's not a procedure that a patient needs to be in the office for. That's something done on the embryos. So think of it this way. I think I have a mole right here. There's my mole. So I have a mole right here. So let's just say I wanted to biopsy my mole and see what's going on with it. So what would I do? I would go into the doctor's office, have that mole biopsied. That mole would then get put in a tube and sent off to a pathology lab. And then I go back home and I just hang out until I get results. Well, it's the same idea. The embryos will stay in the lab after the biopsy. The biopsy will get sent to a genetic testing company, and the genetic testing company will send us a report. It's 2019 right now, March. I imagine that in the not too distant future, there is going to be a way to test embryos that will completely make how we do current testing. It will just make it, obsolete. So there might be non-invasive ways without a biopsy that embryos can be tested and analyzed, but that is yet to come. But certainly I am keeping tabs on all the current trends so that as soon as they're available, if I think that they're appropriate for my patients, I'm going to start talking to them about it and bring them into the lab. So now we're waiting for results. So remember, it's March 6th, period started, and now the cycle is over as far as the hard work goes by March 18th. March 23rd is when we know how many embryos we have biopsied and frozen. And then what will happen is we're going to find out results here. So up there on April 1st, about 2 weeks after the egg retrieval or 1 week after the embryos are biopsied and frozen, we find out how many are genetically normal, and then we'll meet. I call this a post-IVF consult. I really like to do them in person. I don't like to share embryology reports with patients over the phone or email. And here's why. There's a lot of data to present. What I present is the beauty of your embryos, how they rank, the genetic testing results, what they mean, and then we also review the MITO scores. And then we ask ourselves this question: do we have enough embryos for the family size that you want? Yes or no? I'll give you some scenarios. Let's say we have 2 embryos. One is high quality and one is lower quality, but they're both normal. And I have a family that wants 2 kids. And let's say the future mom is 38 years old. My patient's 38. Well, it might make sense to consider doing another cycle so that we feel much better about our chances for having 2 kids. Or we say, you know what, before we do a transfer, let's talk about maybe not doing IVF again and trying naturally, maybe, taking a step back and doing IUI for a couple cycles and not putting her body through IVF. So there are a number of ways that we can help a family reach the family size goals that they want without doing more IVF, but talking about doing more IVF, that's done at the post-IVF consult. So now we go on to step 2. So remember the egg whisperer diet? The D was going through the Tushy method. The I is step 1 in my process. And that step 1 is getting embryos made and making sure they're normal. And now here, this is all step 2. This is implantation testing. I also call this a mock cycle or a rehearsal cycle. For my embryos, I want to make sure that I'm doing the very best for them. I want to go to sleep at night knowing that I don't have any regrets about how I approach someone's transfer. I also want to make sure I discuss all possible tests with my patients and then let them choose whether something is for them or something they would like to skip. If I have a patient, for example, that has 5 embryos that are high quality and genetically normal, well, a lot of times we skip this extra testing. But sometimes it still makes sense to do it if, for example, they have a history of recurrent pregnancy loss, endometriosis. So despite the number of embryos, we may still want to move forward. Here's what we'll learn. Through this cycle, you'll take meds. Number 1, we'll see how you react to the meds. We'll see, is this protocol for you? You're not going to ovulate when you're on these medications. And I tell my patients to live life to the fullest. You can exercise, you can have a cocktail here and there, and you can certainly have sex. Since we're taking over your cycle, let's say if you're used to your period starting here, I can tell you it won't start there because now, because of the medications and everything you've been on, high dose estrogen prevents the ovaries from making a cyst of ovulation. So my protocol is going to be different possibly from your doctor's protocols, but I'm just kind of showing you what I do and you can kind of get a general sense. But just because it's something that I do doesn't mean that what your doctor is doing is wrong. There are so many different ways of making a omelet, so many different ways of making a cookie. I think you know what I mean. So the way I do things is starting cycle day number 1, the next morning you start estrogen tablets, 2 tablets in the morning, 2 tablets at night. I make it super easy for my patients. I say 8 a.m., 8 p.m. with a prenatal and aspirin daily. The aspirin and prenatal don't have to be, are not time sensitive, so they can be taken any day. I have patients come in 2 weeks later for an ultrasound and blood draw. What we want to do is look at the estrogen and progesterone level. We want to make sure the progesterone level is nice and low before a patient starts progesterone. I also want to make sure that the lining is between 9 and 12 millimeters. That's my goal. For the highest implantation rate, that's what I found. For me and my patients, that gives them the highest pregnancy chances. And then we do a biopsy. A biopsy sounds pretty painful, and I can tell you it actually is. What we do is we pass a very thin catheter, and it's also known as a mock embryo transfer, because you're taking a catheter and you're kind of practicing going in. However, instead of pushing cells in like you would with, let's say, an insemination or an HSG, or an embryo transfer, what I'm doing is I have a syringe that's attached to a catheter, I'm pulling back on it, and cells are just going into that catheter. And then I take those cells and I send it to 2 different companies. One company tells me the exact number of hours that your body needs for implantation, and we call that the endometrial receptivity assay. The second company They look at something called the histologic score for BCL6. They tell me if there's inflammation, endometritis, which is infection of the lining of the uterus, as well as the presence of microscopic polyps. So with that information, I can then tell the patient, this is now the right protocol for you, and this is when you need to start progesterone. So after the lining check, I have patients start progesterone at 10 p.m. starting, you can see, let's see here, 1, 2, 3, 4, 5, 6 nights before the biopsy. Depending on your protocol choice, there's endometrin, for example, is one brand of a vaginal insert. I tell patients to do that 3 times a day, 8 a.m., 2 p.m., 8 p.m. The other option is a progesterone injection in the upper outer quadrant of your buttock. That's called progesterone in oil. So if you're going to do that, I tell patients to do 1 ml at night, 100 milligrams, and then they go to 7 to 9 p.m. after that. I give patients an exact time to do things because when I fill out the paperwork for the endometrial receptivity assay, it always asks what time the patient started her medications. And then we always input what time the biopsy was performed, so then we know exactly how many hours of progesterone your body needs. So on the day of the biopsy, it's very similar to the transfer day in that you're going to take a Valium. I also ask my patients to take Tylenol with codeine. I do this because I want patients to be comfortable. I don't want patients to associate experiences in my office with extreme pain or discomfort. If a patient has not had a saline infusion sonogram, let's say you had an HSG over a year ago, I will also take the opportunity to take a look at the cavity a little bit more closely. And sometimes I coordinate this test also with a hysteroscopy. So let's say I know a patient has a polyp and I want it removed. Then on the biopsy day, we can take care of all of these things. Patients will take medications up until the biopsy day and then stop. And the period will start here. You can see around 3 to 5 days later. Once the period starts, I start getting results back, and then I use the results to guide me. So you can see here that this rehearsal cycle or mock cycle basically takes a month or 1 cycle. Once the period starts, we start medications again. And assuming that no changes need to be made with the protocol based on the BCL6 level, we move right into a transfer cycle. Sometimes I'll make a couple tweaks. For example, the reproductive genetic profile may tell me certain things about other additional things that I might do. And again, just because I mention these things, it doesn't mean that the elements that I would add for a certain patient are things that all patients should add. I'm just including things like Lovenox, for example, intralipid infusion, for example, Neupogen, for example, as things that I do in very specific cases, but not in all cases. So for example, when a patient comes in for their lining check for the real transfer, I might also coordinate an intralipid infusion that day because I like to have them done 7 to 10 days before the transfer day. So here you can see, we have the transfer cycle. So we started, if you remember, today on March 6th, and I just kind of showed you all the elements of the 3 steps, starting with the D of the egg whisperer diet, and then we went through step 1, embryo creation, step 2, implantation testing, and step 3, embryo transfer. So the transfer day is going to be May 17th for, let's just say me, I started IVF today, and then the pregnancy test is going to be May 25th. And you can see that, the calendar is empty here because what I do is after that lining check, I populate a new calendar that will include Medrol, which is a steroid that reduces inflammation, doxycycline's an antibiotic that prevents infection, and then we take Valium 30 minutes before the transfer to keep the uterus nice and still and calm. And then patients have the opportunity to do acupuncture throughout this process, and then there is on-site acupuncture available so they can do a pre and post acupuncture appointment. So it's a lot of work, but it's, in my humble opinion, worth it. It's worth it to do the work to build your family so that you never look back with fertility regret. You hear so many people talking about egg freezing, and it seems like everyone is talking about it, everyone is thinking about it, but I think we're ignoring one thing, and that's embryo freezing. I think as a society we can do better because there's so many fertility myths out there, and one of them is that once you get pregnant with baby number 1, baby number 2 is going to be easy, and that's just not true. Of course there are people who have stories of struggling for years and then get pregnant naturally after going through IVF Or even better, what a wonderful story it is when someone adopts a baby and then gets pregnant naturally. But certainly we can't assume that those things are true, because part of the normal aging process is also ovarian aging. And as long as you can't put Botox in the ovary, we have to do the work to create the embryos for the family size that you want in many cases. And as families are waiting longer to start their families because of a number of reasons that are just part of normal societal trends, the steps that I have described to you tonight, I think will hopefully be extremely helpful. So thank you guys for watching tonight's show. I hope I didn't bore the heck out of you, but I certainly can talk about fertility all day long if you couldn't tell. I hope you learned a lot, and you know you can reach out to me through email at eggwhisperer.com, and I'd love to answer your questions and help you however I can. So tune in next week for another exciting show. Well, exciting to me, I hope to you as well. And you guys have a great night. Take care.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Aimee.
She's known as the Egg Whisperer.
Fertility expert Dr. Aimee,
And you have yet another success story.
Just launched by an East Bay fertility doctor.